This is ulcerations of the lower esophagus, stomach, or duodenum. This could be caused by an H. pylori infection, non-steroidal induced, abnormal acid secretion, or Zollinger-Ellison syndrome, which is hypersecretion syndrome. The most common symptom of peptic ulcer is abdominal pain. Depending on their location, peptic ulcers have different names. The gastric ulcer is a peptic ulcer that occurs in the stomach. Usually non-steroidals that are used for arthritis and other painful inflammatory conditions are causes of gastric ulcers. The patient looks malnourished. They can have pain 1/2 hour to 1 hour after meals. Foods do not help, but vomiting does, so they may end up vomiting up blood. Every time they eat, they hurt, so they make themselves throw up. They have a malnourished appearance and low gastric acid levels. The duodenal ulcer is known as an executive type. They're more well-nourished. Nighttime pain in 2 to 3 hours after meals. They have blood in the stools, and the stomach is empty, and then they will begin to hurt, even if it's in the middle of the night. They have high gastric acid levels. The priority of nursing care for patients with peptic ulcer disease is to reduce discomfort, maintain nutritional status, and prevent or rapidly identify and intervene for potential complications. An esophageal ulcer is usually located in the lower section of the esophagus and is often associated with chronic gastroesophageal reflux disease, known as GERD. The clinical signs and symptoms of peptic ulcer is a burning or gnawing epigastric pain 1 to 3 hours after a meal, or this can happen during the night. Common ulcer symptoms are burning, aching pain, or pain that feels like hunger between the navel and the breastbone. The pain extends to the back and flares up at night. Abdomen pain can last from a few minutes to a few hours and usually goes away for a while after taking an antacid or an acid reducer. Patient will experience loss of appetite and weight loss and complain of bloating or nausea after eating. A complication would be mild to severe hemorrhage and is a common complication of peptic ulcer disease. Symptoms include hematemesis, which is vomiting of fresh blood or coffee ground material, passage of bloody stools, hematochezia, or black tarry stools, melena, as well as weakness, orthostasis, syncope, thirst, and sweating caused by the blood loss. Diagnostic evaluation, an upper GI endoscopy for biopsy and cytology, a pylori tech C-urea breath test and serology to test for H. pylori antibodies, barium study, stool samples to detect occult blood, and gastric acid secretion test and serum gastric level test. This would be elevated in the Zollinger-Ellison syndrome. So for the blood test to check for the presence of H. pylori antibodies, the disadvantage of this is that sometimes it can't differentiate between past exposure and current infection. Additionally, a false negative is possible if they've been taking antibiotics or proton pump inhibitors. The breath test uses a radioactive carbon atom to detect H. pylori. The advantage of the breath test is that it can monitor the effectiveness of treatment used to get rid of H. pylori and detect whether the bacteria has been killed or eradicated. Stool antigen test checks for H. pylori in the stool sample. It's useful both in helping to diagnose H. pylori infection and in monitoring the success of treatment. The upper GI outlines the esophagus, stomach, and duodenum. They'll swallow barium that coats the digestive tract, which makes an ulcer more visible. An upper GI can detect some ulcers, but not all. An endoscopy views the upper digestive tract and can identify an ulcer. Because medications now used to treat peptic ulcer disease are so effective, surgery is rarely used to treat. Surgery generally is reserved for people who develop a life-threatening complication of an ulcer, such as severe bleeding, perforation, or obstruction. And in some cases, even these complications can be treated without surgery. Antacids are highly effective agents for healing ulcers and controlling symptoms. However, from a practical perspective, the inconvenient dosing frequency and adverse effects of a therapy limit the use of antacids to symptom control only. H2 receptor antagonists decrease acid production by the stomach and heal almost all duodenal and gastric ulcers after 8 weeks of treatment. Proton pump inhibitors are better at stopping the production of stomach acid and heal almost all duodenal ulcers in 4 weeks and gastric ulcers in 8 weeks. H. pylori is treated with a combination effect in eliminating H. pylori and its usually treatment is 7 to 14 days. An example of treatment for H. pylori is amoxicillin, clarithromycin, and omeprazole. This is a triple drug therapy that uses a proton pump inhibitor and 2 antibiotics. Another example is Prebec, which is Prevacid, Amoxil, and Viaxin. Another one would be Hylidac, which is Pepto-Bismol, Flagyl, and Acromycin. This would be treatment for the peptic ulcer related to H. pylori. It decreases gastric acidity and eliminates the H. pylori infection to cure gastric ulcers. Common causes of GI bleeding are the esophagus and duodenum, and it's most common in males, and it is increasing in females. Erosion is present, and that pain shoots to their back, and they'll have that gnawing feeling when they just ate 30 minutes ago. Liquid and acids are better to coat the stomach. If they can coat the stomach, it will protect the ulcer, because you don't want the acid to get to the ulcer. The overall goal is for the patient to comply with prescribed therapeutic regimen, experience a reduction or absence of discomfort, exhibit no signs of GI complications, have complete healing, and lifestyle changes to prevent recurrence. If the patient suffered a perforation, it would present with an acute abdomen. There is a sudden, intense, continuous epigastric pain that spreads rapidly throughout the abdomen, often becoming prominent in the right lower quadrant and at times referred to one or both shoulders. The patient usually lies still because even deep breathing worsens the pain. Palpation of the abdomen is painful, rebound tenderness, and is prominent. The abdominal muscles are rigid and bowel sounds are diminished or absent. Shock may happen, which is seen by increased pulse rate and decreased blood pressure and decreased urine output. Symptoms may be less notable in elderly and those receiving corticosteroids or immunosuppressants. Discuss with the patient the importance of ambulation would encourage peristalsis, that an NG tube may be placed and must be in working order and patency maintained. Observing for signs of decreased peristalsis and lower abdominal discomfort. Review the need for accurate I's and O's, vital signs every 4 hours, frequent position changes, the IV therapy, and observation for signs of infection. The long-term complication would be pernicious anemia. After surgery, assessing the color, amount, and odor of gastric drainage. The initial drainage is bright red, but it becomes dark, then greenish yellow, and then clear. A change in color, though, could indicate hemorrhage, intestinal obstruction, or infection. Anytime they have an NG tube, monitor the electrolytes. They are at risk for an imbalance in sodium, potassium, and chloride, which can result in metabolic alkalosis. Chronic diarrhea, metabolic acidosis. Listen to the bowel sounds as that indicates the return of peristalsis. Increasing distension may indicate third spacing, obstruction, or infection. And oral feedings are introduced slowly to minimize trauma to the suture lines by possible gastric distension. A Billroth 1 is a gastroduodenoscopy, which is partial gastrectomy with removal of distal 2/3 of the stomach and anastomosis of the gastric stump to the duodenum. It may be performed in cases of stomach cancer, a malfunctioning pyloric valve, gastric obstruction, and peptic ulcers. If the patient has a Billroth procedure and complains of increasing abdominal pain, no bowel sounds, and bright red drainage, could have possibly a post-op hemorrhage and will need a blood transfusion or may need to return to surgery. A Billroth 1 will require a patient to take cobalamin because a deficiency can happen after a partial gastrectomy. A Billroth 2 gastrojejunostomy is partial gastrectomy with removal of distal 2/3 of the stomach and anastomosis of the gastric stump to the jejunum. After a Billroth 2, the patient is at risk for dumping syndrome. They could report dizziness, palpation, and weakness after eating a meal. They would need to lie down for about 30 minutes after eating. After a gastrectomy, it is normal to have absent bowel sounds, incisional pain, and some NG drainage. A complication, a fever. A vangotomy severs a portion of the vagus nerve because the vagus nerve sends impulses to stimulate hydrochloric secretions. This surgery may impair stomach emptying. The purpose of the procedure is to disable the acid-producing capacity of the stomach, and it is used when ulcers in the stomach and the duodenum do not respond to medications and changes in diet. It is an appropriate surgery when there are ulcer complications, such as obstruction of digestive flow, bleeding, or perforation. A vangotomy procedure is often performed in conjunction with Partial removal of the stomach, which is an antrectomy or subtotal gastrectomy. Antrectomy is which the lower part of the stomach is removed. This part manufactures the hormones responsible for stimulation of digestive juices. Pyloroplasty, which enlarges the opening into the small intestine so that the stomach contents can pass into it more easily. A complication would be a sudden intense mid-epigastric pain that radiates to the right shoulder, may indicate an ulcer perforation. If the patient was going to go for a C-urea breath test, they need to stop proton pump inhibitors 2 weeks before, as it could cause a false negative result. Remember though, complications would be GI hemorrhage, gastric outlet obstruction, or dumping syndrome. Post-op management is to reduce pain, anxiety, and maintain an optimal nutritional status, monitoring and managing potential complications like hemorrhage, perforation, and pyloric obstruction. Patient would need to eat in a low Fowler's position. They lie down after a meal, would go on their left side. Eat smaller meals, consuming about 6 small meals a day rather than 3 large ones. Avoid fluids with meals. Drink liquids only between meals. Change the makeup of the diet. Limit their carbs. No simple sugars. Avoid hot and cold food. And anticholinergic or antispasmodic medications may be given. They need to consume more protein in the diet and adopt a high fiber diet. Moderate fat, high protein diet. The fat slows down the gastric motility and the proteins increase colloidal osmotic pressure and prevent shifting of plasma. Increase pectin intake. Pectin is found in many fruits such as peaches, apples, and plums, as well as fiber supplements. Pectin can delay the absorption of carbohydrates in the small intestine. Tell the patient to stay away from acidic foods. Tomatoes and citrus fruits are harder for some people to digest. Use low-fat cooking methods. Prepare meat and other foods by broiling, baking, or grilling. Consume vitamins, iron, and calcium. These are sometimes often depleted after stomach surgery. And again, lying down after eating because it could slow down the movement of food into the intestine. They would need to eliminate use of nonsteroidals and other medications that would cause the ulcer. Stop smoking because this impairs the healing. So post-op, monitoring their eyes and nose to avoid fluid volume deficit because IV fluids and blood might be needed. Check their hemoglobin, hematocrit, electrolytes, and stool for blood. NG tube insertion to check the drainage for blood. Look for signs of shock, increased pulse, decreased blood pressure. Patient probably will need analgesics, maybe some antidiarrheal medications, and remember the high calorie, high protein, and small frequent meals. Dumping syndrome occurs in 33 to 50% of patients after surgery. Direct result of surgical removal of the large portion of the stomach and the pyloric sphincter. There's a decreased ability of the stomach to control amount of gastric chyme entering the small intestine, and a large bolus of hypertonic fluid enters the intestine, which increases the fluid drawn into the bowel lumen. Dumping syndrome occurs when the contents of the stomach empty too quickly into the small intestine. The partially digested food draws excess fluid into the small intestine, causing nausea, cramping, diarrhea, sweating, faintness, and palpitations. It usually occurs after consumption of too much simple or refined sugar in people who've had surgery to modify or remove all or part of the stomach. Occurs at the end of a meal or 15 to 30 minutes after eating. And symptoms would include weakness, sweating, palpitations, dizziness, abdominal cramps, borborygmi, and the urge to defecate. Discharge to home. It's important that changes in lifestyle such as improved nutrition, stop smoking, decrease alcohol, and stress reduction strategies are discussed. Eat 5 to 6 small meals a day instead of 3 larger ones. It's important that they do not overeat. The frequent smaller meals are more comfortable and easier on the stomach than 2 or 3 large meals a day. Eat a diet rich in fiber, especially from fruits and vegetables. Rest and relax a few minutes before and after each meal, as well as remaining relaxed during meals. Eat slowly and chew the food well. Avoid eating within 3 hours before bedtime. Eat foods that are low fat. Avoid foods that are fried and spicy, and cut down on the following foods: coffee, decaf coffee, tea, cola drinks, carbonated beverages, citrus fruits, tomato-based products, chocolate, alcohol, and again, quit smoking.